going to introduce our oncology team. We're going to get started. We have a couple more people still coming in. Also, I'd like to thank Christine, who's out in the hall doing all the work for setting this up. If you haven't signed in with Christine, if you could just tell her on the sheet afterwards, that'd be great. And we'd also like to thank the Pet Trust, and they have some stuff out there for you as well. The Pet Trust has supported the oncology service with some of the people here today, definitely with the Animal Cancer Center, and with also some of the business projects as well. So special thanks to the Pet Trust again for supporting tonight. And we're going to sort of introduce the oncology team, and then we're going to talk osteosarcoma. It's meant to be interactive, so if you have any questions, just yell them out, and then we'll remind our people to repeat the question, because we're also on the mic here with Kevin as well. So let's introduce the oncology team. For medical oncology, Danielle Richardson, who's not here because she just had a baby boy 2 weeks ago. So Danielle Richardson is a medical oncology internal medicine person, and she just had a baby boy, Reese Elliott. So we're excited by that. Tony Mutsaers will be coming in later. He'll be the abnormally tall person coming off in the Senate meeting just across the hall. And then I'm Paul Woods. For surgical oncology, we have Michelle Oblak, who will be talking osteosarcoma. For radiation oncology, we'll have to talk very loud. This Valerie Poirier, who's off-site, she's a radiation oncologist, has moved with her family to New Zealand, so is doing planning from off-site. And right now, we're seeking a radiation oncologist in the Northern Hemisphere. For medical oncology, we have our DVSc residents. We have Jerome Calvalido from France. Steve Pack from Ontario. Yeah. And we have Arana Masuyama from Japan, who's actually doing a PhD with Tony Mutsaers as well as a residency. We have an oncology intern from Michigan State, graduate from South Korea originally, Chang Kim. And then we also have our surgical oncology intern, Shannon Weinberg from Ontario. And since we're introducing, we'll just say that we also have visiting from us, is we also have Charlotte Johnson, who's a resident at Western College in Saskatoon, who's now visiting with us as well. Okay. Oncology technicians, there are a lot of people in your clients, so our clients are going to be up with most of the time. We'll be Mel Brooks, Vicky Heinrich, or Terry Dickinson. We also have 2 radiation therapists. We have Laura and Kate, who are radiation therapy. And then also later tonight, we'll be here will be our clinical trial supporter, Vicky Sabine. And I need to put in my infomercial. If you haven't picked one up yet, Vicky put these together at the desk there showing the clinical trials that we're doing at the Internal Veterinary College as well. And Vicky's very good for you to contact. There's information in there. If for some of the trials you have a pet that you think would fit into the trial. And then Kaya Skoronsky, who is our tumor banker, and she also helps Vicky with some of the clinical trials, but also banking the pets here for tumor banking as well. And then also we have our clinical counselor, Janet Kalendi, supported by the Pet Trust. She's at OBC on Tuesdays and Thursdays, and also helps with grief support as well on Tuesday nights as well. So she's a great resource for us. Pathobiology, this is their building, so we also have clinical pathology and anatomical pathology. We use the pathobiology team, and so we're very great for getting things turned around. Also, though, we also get second opinions, and so we get second opinions internally, but also we also get slides sent in from you guys as well, getting second opinions as well. Which is a big thing when we're making plans to see, does everybody agree or does everybody not agree on what we know about that case as well. So we have all this team here at the medical oncology and veterinary surgical oncology and radiation oncology at the Animal Cancer Center. And we also have the Lower Campbell Center for Animal Cancer, which is supported by the Pet Trust. And so what we are is a comprehensive cancer center, and you guys are sending cases in here for diagnostics, but also for therapy. So we have surgery, radiation, chemotherapy, and then we also have investigational therapies and immunotherapies as well. We have counseling, and then we have education, because we have in the back of this room 4 student veterinarians who are on oncology this week and are planning to graduate this spring. Okay, let me give it over to Michelle.
Right, thank you everybody for coming. I was also asked just to let anyone who's watching at home know that we are live streaming and live tweeting this as well. So if you have any questions, you're welcome to get involved. Just tweet at Ontario College, and we'll be able to answer those questions. So I'm not going to spend a lot of time on this part because really you guys mostly will know in terms of your history diagnoses, you're probably seeing more osteos than here, because obviously a lot of them aren't making it this far. But just kind of as a quick overview, it is the most common primary bone tumor, more common in dogs than cats. And the stats say anywhere from 85 to 95% of primary bone tumor is diagnosed. So realistically for me, when I see any dog with a lytic bone lesion and classic location that has an appropriate settlement, I'm thinking osteo, I'm thinking osteo again, and then maybe about 5 differentials down, I'll start looking for something else. So especially around here, we very, very rarely see fungal osteomyelitis. So that tends to be kind of a second differential. If we're thinking about things like multiple myeloma or other multifocal disease, then we're going to find those usually on our physical exam. You're going to find multiple lesions, you're going to find other abnormalities. So the vast majority of cases that present with a primary bone tumor are going to be osteos. And usually it's the long bones. So we see them at other sites. We see them orally fairly often. We'll see them on the ribs. We'll see them in the pelvic area. But most often you're going to see these guys presenting with a lytic bone lesion of the appendicular skeleton. So you have your typical segment of large and giant breed dogs. Your age, the median tends to be around 7 years. But there is this biphasic peak with the osteos. And so if you see a really young dog with a lytic bone lesion, you can still think about that being potential osteo as well. And so we see them kind of in that 18 to 24 months occasionally as well. And unfortunately, those dogs tend to have a slightly more aggressive form of disease. If Osteosarcoma is aggressive already. So these guys will present from anything from a mild to a severe lameness. The challenging thing with history is sometimes they can have a fairly chronic history because they presented with this sort of waxing and waning lameness, a mild lameness, progressive lameness, and then they present because they've now developed a pathologic fracture. And unfortunately, some owners just aren't that astute. They don't notice, especially with forelimbs, they don't notice the lameness until it becomes quite severe. And so it's not always that it has this chronic nature that you can realize that this could be related to a bone lesion. And then pathologic fracture, unfortunately, can be sort of the end stage that we see in these guys. So a couple of cases of sort of your typical presentations. So you can see the image on the right is actually had a biopsy. You can see the scar there. This is your other kind of classic. So quite frequently distal radius. Most of the osteos we're seeing are going to be distal radius, and then we're going to move away from there. Okay. A couple examples of a pretty severe pathologic fracture. But amazingly, a lot of times the bone changes do not have to be that significant. So really, any time you get an animal presenting with a low impact fracture, especially in history of an older animal that just went out in the backyard and was walking around and suddenly presents really lean, you want to make sure that you keep that differential on your list because it's really easy to miss. And so sometimes we look at these radiographs and we're like, that cortex just looks a little bit abnormal or unusual. And so just always have it on your differential list when you have these animals that don't really have a trauma that fits with the change that you're seeing. Location is another key. So you want it to fit with that normal clinical picture. So your common sites are going to be the same sites that you're going to see your increased growth from growth plates, right? So it's the same kind of area. So you're going to see your distal radius, your proximal humerus, your distal femur, and then the tibia kind of doesn't really follow the rules, so you can see either distal or proximal. But the general rule of thumb is going to be away from the elbow and femur. Above and beyond, the most common we're going to see is that distal radius. We definitely see a fair number in the tibia as well. The nice thing with both of those sites, as we'll talk about later, is that it's quite an easy surgery with the amputation because you don't have to worry about taking that bone margin because you're already there. Just a couple examples. I think everyone who would look at these two radiographs would probably say, that's probably not normal. So, looking at those, we know there's this one. Even though there's not an obvious what we call a fracture, if there's a disruption in a cortex, it's a fracture. So we get lots of cases being referred saying, oh, well, it has a lytic bone lesion, but there's no fracture. Well, if there's no cortex, then of course it's fractured. It's just not the standard classification of fracture. So that's not necessarily that important unless you're thinking about limb-sparing options, because we generally don't pursue limb-sparing options if we have a more severe progression of disease and a lot of change in the bone. So that's why it really becomes important. This lesion here is obviously a lot more subtle. So if we take a look here, you can just see just a little bit of lyticness to this. There's a tiny, tiny bit of periosteal reaction there. The was a little bit of end osteo reaction. And one of the earliest signs that we'll see is just that, just an end osteo reaction and nothing more. And so anytime an animal is presenting, especially if they have pain on palpation, then it's going to be important to keep that in mind. Your orthopedic exam is actually one of the best tools we have to pick up some of these subtle early bone lesions before we do anything else. But radiographs aren't always going to give us that answer. So a lot of times you can find a lesion actually on palpation that you may or may not see if it's early enough on radiographs, and then we have to think about going to CT. So I'm going to pass it off now, and we'll just talk a little bit about staging. The left one is the player, the right one is the
Alright, so I'm going to briefly talk about staging, which is a pretty important part of the management of osteosarcomas. Because that determines if animals are with surgical candidates, having more less advanced disease, etc. So, Michel explained the radiographic, the classic radiographic appearance of osteosarcoma, but it's not pathognomonic for osteosarcoma. Those radiographs that she showed can be consistent with other bone cancers or other tumors. So there are other differentials. For example, among the other primary bone tumors, we have chondrosarcoma, we have fibrosarcoma. We can also have metastatic cancer, and for this, the location can help differentiate. If we have metaphyseal lesion, then it's one flavor of a primary bone cancer, versus if it's diaphyseal, for example. It's more consistent or suggestive for metastatic cancer. Also, multiple myeloma or lymphoma, which are not truly primary bone cancers, as bone lesions, always have infections, bacterial or fungal, in the differential list. Although we always tell the owner that if there is no history of traveling outside Ontario, if there is no entry site for bacterial infection, if the dog is doing well otherwise, bacterial infection or fungal infection are less likely. Bone cyst is also on the differential list, but it's usually better defined, well circumscribed lesions with not a lot of periosteal reaction or very aggressive bone motility or proliferation. So let's just take another type of tumor or another process which have an unusual synonyms or locations. So, like I said, diaphysis of bone, also lumbar vertebra, which can be more associated with metastatic cancers like prostate, for example. A history of other cancer, obviously, and if you have entirely lytic lesions on radiographs, there can be more already complicated lesions that can be more into the bone of multiple myeloma or lymphoma. So we have talked about radiographic appearance and so now, if you have a radiograph like you saw previously, it's good to recommend to try to confirm the diagnosis, even if it's like a Burmese mounted dog, the store radius is 7, 8 years old. It's always good to have the confirmation. And like historically, bone biopsy was the first choice and still considered the gold standard. But now we prefer to start with cytology because it's less invasive. We just do finding aspirate. We don't need anesthesia, sedation is sufficient. And we have a pretty good accuracy, sensitivity and specificity, which are 100% and 95% respectively. So it's pretty 80-90%, sorry. And if we have a special staining like ALP, we can increase the specificity of the lead and especially differentiate osteosarcoma from other sarcomas like chondrosarcoma or fibrosarcoma. It's not 100% specific, like it's reported for example chondrosarcoma. There is at least one news report that's staining positive for ALP, but it's otherwise extremely rare. And the immense majority of these neoplastic cells that stain for ALP are from osteosarcoma. Bone biopsy, we reserve it mainly if cytology was non-diagnostic and the owners want absolutely confirmation. Although at this point, if you have, once again, classic textbook presentation with severe lytic bone lesion, historeduced, classic grade, classic age, it's fine to go to surgery for amputation, even without firm confirmation. Because anyway, the treatment options at that time are limited, and amputations are almost always recommended. But someone just wants to absolutely confirm it, and that's very fine. That's the idea of and we use density needle biopsy, and you can see accuracy is 92%. And 80% for to determine a specific subtype. But it's also more invasive. You need anesthesia, and you have a low risk, but that's a risk that is presented in fracture because you have a bone that is already fragile from the tumor analysis, and you're gonna do an even bigger hole. So that's something to keep in mind with the owners. So briefly, that's the technique for density biopsy. So you do just a small incision, then you insert the needle. And something important is to try to reach the center because that's where you have the best chance for diagnosis compared to other tumors where you may have a necrotic center that you want to avoid. In osteosarcomas, the center is the best spot. And there are different sizes of needles that you can use depending on the size of the needle. That's the summary. So for the rest of the staging, blood work is always important for the of cancer. Make sure that the bone is healthy, otherwise we can have indirect evidence of spreading. If you have like super elevated liver enzymes, and for example, in favor of liver infiltration. You have also some prognostic factors, which is known as ALP, which is associated with more aggressive osteosarcomas and poor prognosis. Orthopedic examination, like Michelle told you, is very important to try to detect any other focal painful spots that may be indicative or suggestive of bone metastasis. Abdominal palpation to try to detect a mass effect that can be also a sign of spreading. The lymph node aspiration, so osteosarcoma is not typically spreading through the lymphatic system or through blood. And so as you can see, the chance of finding metastasis is pretty low, less than 5%. But we know also that it's associated with poor prognosis, 16 days. So that's important. As long as you can palpate it, even if it's not super big or firm, through sampling, because that can make a difference in terms of prognosis. bone survey radiographs. It can be done, but it's a lot of views. You probably need sedation to do all those views. And you find metastasis in less than 10% of cases. This radiograph here was taken from a dog that was diagnosed with an osteosarcoma of Distal and that was 4 or 5 months ago, I think. He was amputated and was doing well until a week or 2 ago, where he was suddenly more weaker. And on physical exam, there was not super painful focal spot, but he was limping from the other pelvic clearly. So we did a radiograph, and you can see here in the distal diaphysis, there are punctate bone lytic lesion and some periosteal reaction here, and that was consistent with metastasis. So this was 4 or 5 months after, but that can happen also at the time of diagnosis. So if you have a focal pain in your orthopedic exam, you can X-ray to see if there is not an aggressive nodular. Chest radiographs very important because osteosarcoma spreads mainly through the blood system. At the time of diagnosis, once again, it's relatively uncommon that we find pulmonary nodules, but when it happens, obviously, it's associated with poor prognosis, usually less than 3 months, regardless of what we do. And so amputation may be recommended. Abdominal ultrasound, you can see even lower yield compared to the other tests to find metastasis, 2.5%. But once again, prognosis can be affected. More interested in one study, 5% of those had another primary tumor found by abdominal ultrasound. And so that's something important to remember, and sometimes you can be surprised that we do like all the tests, like chest radiographs, abdominal ultrasound in a lot of cases, if not every cases. But it's because we see geriatric patients, and it's not rare. We can see that regularly. Those that come with one cancer, with the staging, and we find another cancer that is sometimes even worse than the first one. And so that's why we become a little bit paranoid, but it's not just we find those things in practice. If you wanted to take a step further, it's can be a good option. People are offering it more and more. Now it's more available in practices. And so I just inserted 2 images. One here you have a pulmonary nodule, here another pulmonary nodule, and here is an abstract from a paper that was concerning osteosarcoma specifically. And they compared chest X-rays and CT of thorax. And they found 5% of cases with X-rays on the had nodules visible versus 28% with CT. So the sensitivity is much better with CT. It's around 1-2 millimeter versus, depending on the studies for chest X-rays, 6 to 9 millimeter. And the only thing is that in this paper they say whether nodules were present in CT or not do not influence overall survival. And that's something we don't really know at this point. That's what we call stage migration. Because pretty much all the studies were done that looked at survival were based on X-rays. And so a lot of probably those cases were deemed determined clear of metastasis at the time of diagnosis, and maybe some of them were had metastasis if we had done the CAT scan. But we don't know really the difference in terms of prognosis, so we don't really know should the dog that had that has one nodule, like 2 millimeter on CT, should we not do an amputation on this dog? We don't really know. Because he can live 8 months, who knows, because we didn't look at that. Another more advanced staging test is bone scan scintigraphy. So we inject a radionuclide, technetium-99, and we do a whole bone, whole body scintigraphy. Sorry. And that's here a picture of the bone scan that was done on the dog. So it's quite sensitive to detect the regions that have significant osteoblastic activity. The problem is it's not very specific. So a region of arthritis, infection can show up on your bone scan. So you need to confirm if something appears on your bone scan. You need other more classic imaging devices like X-rays or CT to precise if it's just arthritis, for example, or if it's really an aggressive bone lesion. But that's something that we offer here because that can detect potentially metastasis, especially bone metastasis. So here we have an example of a body with 2, 3 metastases. The problem is specificity, like I said, and I'm going to illustrate that with an example, a dog that we have seen here, named Buddha. And Buddha had a classic distal radius osteosarcoma, and we offered the bone scan. People agreed to that. On orthopedic exam, there was no abnormality. We did the bone scan, and then on one of the distal tibia, there was this focal lesion. And the radiologists here were pretty much convinced it was metastasis. And so we told that to the owner, but we needed an X-ray to confirm. So that's what we did. And you have the X-ray here. And that's the region that was supposed to be contain the metastasis. And it was normal on X-ray. So we were a bit embarrassed. So the next step was CAT scan. And we did the CAT scan, and there was nothing either, no aggressive combination. And so after discussion with the owner, we still had the distal radius osteosarcoma. It was painful. We didn't know what to do with this lesion on the scan. At the end, the owners decided to amputate anyway and to monitor the distal tibia. And that was a year ago, and he's still doing great. And nothing on this tibia. So everything to say that it's a very good screening test, sensitive, but you have to confirm with other imaging devices, and sometimes it's not. It's not always you have other newer staging options like PET scan, for example, which is the combination of scintigraphy and the whole body CT, whole body CT. But it's very experimental for now, but it's something that we will use in the future to be even more sensitive in staging. So now we're going to have
person speak? Who's speaking? You? Okay, so let's go in a pocket. That's true.
So I just hold this.
Yeah, sure.
What's this one? Alrighty, so I'm going to start off by talking about, so we'll do it this way. Okay, so surgical treatment options for osteosarcoma. Start off with the kind of the more traditional technique that everyone's probably more familiar with, which is amputation, and then discuss different options for patients for patient reasons or for owner reasons where limb-sparing procedures might be indicated or desired. So starting off with amputation. Patient selection. So amputation is the gold standard treatment for osteosarcoma. Can be used in primary or metastatic bone tumor for local pain control. So these patients, as everybody sees, is typically very painful and uncomfortable. So it is a treatment option to manage the local disease in addition to, in certain cases, maybe delay the onset of metastasis. But more typically, this is for local control and reducing pain associated with these patients. There are some thoughts out there that, patients that are larger, so St. Bernards and Great Danes don't do as well with amputation, but we see here in hospital, they do very well. It sometimes takes them a little bit more time to get back up and moving around on their 3 legs, but we don't see restriction by size or weight or previous limb surgery, so TPLO patients and things like that, or the presence of degenerative joint disease. So different options for forelimb amputation. So scapulothoracic disarticulation, so amputation high up on the scapula. So the entire limb is removed from toe to scapula. The thoracic limb only has muscular attachments to the body wall, so not cutting through bone. So easier in primary practice where you might not have all the orthopedic equipment required, and then using nerve blocks for the nerves, and then ligating the axillary artery. So something that's fairly easy to do in primary practice, especially in cats and small dogs. Getting into larger breed dogs, managing bleeding and things like that, hemorrhage can be more difficult. So if you'll be doing a lot of these on large breed dogs, things like Cotter, you might be something worth investing in. But overall, even on the large breed dogs, as long as you're kind of incising at the upper neurosis of the tendon versus through the muscle, then bleeding can typically be well managed. And it can do well. Another type of forelimb amputation is the mid-humeral amputation. And this can be done in neoplasia distal to the elbow. Difficulty with it, which is why we don't recommend it, is that patients don't typically do as well. Cosmetically for owners, we see muscle atrophy, which is not really pleasant for owners to look at. When patients have that stump, they will kind of try to walk on it, which can be traumatizing for the owners, but can also be traumatizing to the patient themselves and trying to ambulate on it. So I have a picture here of a dog that did have that done that is using a prosthetic, which there'll be a couple slides later on prosthetic, but we typically don't recommend it. Situations it can be used in is if not really left with an option if the dog has, for whatever reason, can't have its limb amputated, or owners are really not for full limb amputation, then it's something that is available. For the hind limb, coxofemoral disarticulation, so neoplasia affecting the femur. It's more symmetrical than the other technique, which is mid-femoral amputation. So similar to kind of mid-humeral, we'll see muscle atrophy associated with that stump. So typically not as cosmetic for owners and for the dog. Post-operative care, so these patients do very well, and possibly manage them on systemic opioids and NSAIDs. We also have a diffusion catheter, which we use here. It's kind of being passed around right now. So the bupivacaine is administered through the diffusion catheter, and as you can see in the picture, and as it comes around with the saline attached, you're free to kind of push on and see, but it kind of sprinkles. It's like a sprinkle. It's sprinkler, sorry. It's diffuses the local anesthetic throughout the muscle in the area where we've done the amputation, and provides amazing local pain control. So we've noticed here in hospital when patients have this diffusion pain catheter in, they typically go off CRIs much quicker, kind of are up and moving around and less painful. So they're not very expensive per catheter. I think they're like $30, $40. So definitely something that we find very valuable here. And if you're doing a lot of amputations, would probably be a valuable resource to stock in your clinic. Bandaging, so putting some sort of compression around that area. The amputations typically will form a large seroma. So bandaging and compression when possible. And then they're usually in our hospital for about 2 to 3 days. In terms of drain, it is a site that we've amputated and removed a source of cancer from, so we don't typically like to put drains through those sites. If you're dealing with an area where there's a lot of fluid, we prefer bandaging and applying compression and things like that, but a drain can be used. Similar to the diffusion pain catheter, we don't like to leave the pain catheter in for more than about 72 hours just because of the risk of infection with an opening into the area of the site. So that would be kind of a similar philosophy for the drain. If you are using it, we don't recommend leaving it in very long. And we find most of our patients here will start ambulating within 1 day of surgery. So typically do very well and adjust very well. Potential complications we kind of discussed, seroma formation, so compression shirts. The Thunder shirts that are on the market work well for certain dogs, depending on size. And then infection. So we do put a lot of our amputations on a short course of antibiotics post-op just because of the large incision and this skin that we're going through, and being in hospital here with our ICU, just the risk of exposure to a lot of bacteria and hospital-acquired infections. So we do put our patients on antibiotics for short-term afterward to prevent infection. Client satisfaction is very good. Median time to maximal adaptation to being on 3 legs is usually around 4 weeks. You will see, gait changes associated with thoracic and pelvic limbs on how the patient moves, but they do very well and are back moving around pretty quickly. And for amputation patients, typically require very little to no post-op rehabilitation, so physical therapy, versus when we get into the limb spare, that's something that those patients typically require for quite a long period of time. In terms of things for owners, when dealing with patients after an amputation, especially large breed dogs, there are a few great products on the market. So Tripods makes harnesses specifically for dogs that are with 3 legs. So kind of similar to Help Them Up harnesses. They do have that handle on them to help owners help move them around and help them in ambulating. So a really good resource. Okay, still working? Excellent. Okay, so a lot of you probably, maybe some of you are doing amputations in practice, maybe not a lot. A lot of people tend to be a little bit afraid to do amputations. Honestly, the technique itself is not that difficult, especially if you're dealing with a distal radial osteo and you don't need to worry about having a lot of involvement proximally, then you can really cut along most of those aponeuroses, and there's actually not a lot of muscle to cut. So if you really review that anatomy, it can be a fairly straightforward surgery. One of the things I'd really recommend, if you guys didn't get a chance to see that pain catheter, we'll have it up at the front, and I'd really recommend, if you are doing amputations, to consider the pain catheters. You can use them as intermittent, so you can use bupivacaine in them, and you can give it every 4 to 6 hours, usually somewhere around 0.1 mils per kilo. The other option is that you can actually put them on a CRI. So if you're in a facility where you don't necessarily have overnight care and you're looking at keeping this patient in hospital and maybe having a good 6-8 hour window where there's nobody there and there's no pain meds, then that local infusion can be pretty amazing. So we have a lot of patients, like Shannon said, a lot of them are on opioids. We give them hydro intermittently because we feel like it's wrong not to. But quite honestly, a lot of those guys are very sedate. And we actually have concerns sometimes that that's probably too much for them.
And so really that local infusion between the infusion of the nerves in surgery and the local infusion afterwards is really helpful. Works really, really well. And I've noticed a big difference in terms of the post-op recovery. The other really nice thing is the less sedate the patient is, the less unsure they are on their feet. So they tend to hop up a lot quicker because they seem to be really comfortable, even if they haven't necessarily been on 3 legs all the way through. The other thing about amputations that I think it's important to keep in mind is it's extremely rare to find a patient that cannot tolerate an amputation. So the vast majority of cases, these dogs actually do very well and can tolerate an amputation. Even dogs that have had bilateral TPLOs, even dogs that have hip dysplasia. We're in a situation where if you're looking at an animal that has really bad, painful bone disease, they're already a lot of the time not using the leg. And if they are using the leg, there's ways to sort of assess whether or not they can ambulate. But I've been amazed, even big, huge St. Bernards that you're like, there's no way that dog can do well with a 4-limb amp. 90-kilo Great Danes, they often do well. So it's pretty rare. I've had very, very few cases where dogs don't do well if they can tolerate the 3 legs. But orthopedic disease doesn't necessarily preclude. That being said, a very overweight lab that can barely walk to begin with that has bad elbows and knees, maybe those situations we're going to have to take a step back and figure out what else to do. So I'll talk a little bit about limb sparing. Quite honestly, limb sparing is going to be something you probably are going to run into a lot of questions about in practice. It's extremely rare that we have good limb sparing candidates. So I've been back at OVC for about 2.5 years now, and I've had 1 dog that was a good candidate for a limb spare. So think about all the cases that we have been going through. Really, limb sparing really only seems to work on the distal radius osteos. So anything beyond distal radius, we really haven't done a very good job with that technique. Even then, it's really not, it's very complicated. It's not a straightforward situation. And so we really try and reserve it for those patients where we have no other options. So patient selection with these guys is key. And what I always say to the owners when I go into a room and talk to them about limb sparing is that you have to talk me into doing this surgery. So a lot of these limb sparing surgeries are really fun. It's great. It's really interesting. I love doing them because the surgery itself is great. But really, I need an owner who's saying to me, here's what I've looked up, this is what I know, and this is why I think that my dog is a good candidate. We had a client like that recently, and he came in and he said, I know that amputation is the best option for my dog. I know that I have other options. I know that my dog would do totally fine on 3 legs, but I really want to give him a chance. I know these are the 5 complications I'm worried about. I know half of these get infected. I know it's going to cost $10,000, and I'm okay with all those things. And so I said, well, I can't really argue with you. And so I did it. Unfortunately, that dog actually ended up with an amputation in the end. So in that situation, the limb spare went really, really well. He recovered fantastically. He did well for a few days, and then he started to get infected, which we know a lot of them happen. And we treated it very aggressively, very quickly. But ultimately, at the end of the day, in that case, the limb got so infected that if this was a dog that couldn't live on 3 legs, we would have kept going. I could have managed this dog with bandages. I could have saved that leg. But this was a dog that actually was very orthopedically sound and could live on 3 legs. And so I talked to the owner, and we talked about the options, and then he decided to do an amputation. So it's really not for the faint of heart. And even when the surgery goes perfectly, it's unfortunately a really high risk of infection. So there's really not a lot of situations where these guys are going to be candidates because of the soft tissue involvement. So essentially, in order to be a good limb sparing candidate, you have to have a very minimal lytic bony lesion of the distal radius that has minimal soft tissue involvement, that doesn't have a pathologic fracture, that ideally has not been biopsied, that doesn't involve the ulna in most cases, although there are some exceptions to that, and that doesn't involve more than 50% of the length of the bone. So that's a lot of criteria. And those are just the cases that we know probably do the best. But even within that, there's some other cases in terms of the overall subsets. And it wants to go backwards, but not forwards. So in most of these techniques, we're essentially looking at trying to spare as much skin as possible, which is why the soft tissue involvement is really important. And then we're aiming for a 2 to 3 centimeter margin beyond the abnormal bone. So we're aiming for a 2 to 3 centimeter margin, which is why that kind of maximal 50% comes in, because we need to have bone to still be able to put into that implant. I'll talk a little bit about scapulectomy. Scapulectomy is a little bit of an unusual situation. I'd consider it in the limb sparing category, but it's not associated with the same complications because we're not putting any implants in. Again, very unusual that we get a primary scapular osteosarcoma or primary scapular lesion that we can offer a scapulectomy for. So probably not something you're going to see a ton, but keep that in mind if you do see those cases. You're going to hear about probably 20 different types of limb sparing techniques. There's techniques where you take bone from another dog that's been in a bone bank, so a dead cadaver dog. There's techniques where you take the actual piece of bone and you fry it and radiate it and then put it back in. There's techniques where you take that bone, you scrape it out, you try and take all the tumor out, and then you fill it with bone cement and you put plates and things on. There's techniques where you put just metal spacers on. There's tons of different ways. And so what that tells you is we probably haven't perfected it yet. Because if we had a really good technique, we'd really probably focus on one. In general, the techniques right now that seem to be the most commonly used between surgical oncologists and the veterinary side of things are going to be the endoprosthesis, which is the metal implant. So we're taking out that chunk of abnormal bone and replacing it with a metal bone conduit implant. The other thing that you may hear about, and this is something that people may find online, is the lateral manus translation. In that case, the thought is that if we can avoid putting that big, huge chunk of metal, that maybe there's a little less hardware in there, a little less risk of infection. It's not very well published on. One of the godfathers of surgical oncology and one of the people who've done a lot of these is Bernard Seguin in Colorado. And he does very well with them, and he still finds that there's certain issues and complications, and infection is still the biggest concern. And then there's this whole discussion of prosthetics. What we know in people is that prosthetics are very complicated. They're not straightforward in the sense that they have a lot of pain associated with them. They have a lot of infection. They have issues with the osteointegration of trying to get that skin and the bone interface to heal. They have issues with actually trying to have function. And so there's some kind of random reports out there, and people have started doing them and stopped doing them, and you may be able to find people here and there that might be willing to do them for the right case. But as a general rule of thumb, it's really not that widespread. There's prosthetics that are implantable, and then there's the external prosthetics. There's going to be different pros and cons to each of those as well. So we'll start out just with a case that we had that was for neoplasia of the scapula. So in this case, it was an osteosarcoma that was completely confined to the scapula. And those case situations, you can talk about either total or partial scapulectomies. When you talk about either technique, especially a total scapulectomy or technically probably a subtotal scapulectomy, when you're taking about 95%, you're going to see a functional lameness. So these dogs are no longer painful, but we have cut some of those extensor and flexor muscles, so those dogs aren't going to have a normal gait, but they're going to be pain-free and they're going to conserve and maintain the limb. Let's see if I can make this play. So this is just a quick scan through the CT on this particular dog. So in this dog, if you keep an eye on the screen, right in here, you're going to notice that there's a fairly significant soft tissue mass coming in along here. And as you continue to watch along the scapular spine, you're going to notice that there's a bony change occurring. So a lot of periosteal reaction, some lysis of the scapular spine. And so in this particular dog, the dog was presenting for only pain and swelling and a bony lesion associated with the scapula, but there was no effect on the humerus. So the humerus was completely fine. The mass appeared to be fairly well contained, but spiculated and coming directly off that scapular spine. So this is the same dog. On the left-hand side of the screen, you're going to see this dog immediately after surgery. Now notice he's an Arctic breed, and so he had a lot to say. He was quite dramatic about the whole situation. He wasn't particularly happy about it, but he was, initially quite willing to place the limb occasionally, but needing a lot of assistance. So this dog could have done fine with an amputation. It would have been a lot quicker, the recovery would have been faster, and quite honestly, the dog would have done completely fine. He was orthopedically sound. There wasn't a good reason to spare his limb, other than the owner preferred to. And in this case, it seemed like a reasonable situation. Confined to the scapula, they understood that he was going to have a functional lameness. This is the same dog 4 weeks after surgery. So you'll notice that he tends to keep the limb up, and it's tough because this is when he's walking fairly quickly, but as soon as he slows down, he's now placing that limb a lot better than he was before. And then in this final image, I think, is this 6 weeks, 8 weeks, somewhere around there? Oh, this one's 4 weeks. Okay, sorry, 2 weeks and 4 weeks. In this case, you can start to see he's using the limb significantly more now. He is still very functionally lame, so this is not a normal dog walking. You can see that there's a lot of change. But for this owner, they were very, very happy with this outcome. They were very happy that they could keep the limb on this dog. They did aggressive physio, so they took him for physio, they did underwater treadmill, but it was really important to them that they can maintain the leg. It's important to remember too that this is a functional lameness. So this dog is functionally lame because he has abnormal muscle characters, but he's not painful. So there's no pain associated with this. We often associate lameness and pain together, but this is not one of those situations. So I mentioned briefly the endoprosthesis. So essentially the endoprosthesis is taking out that chunk of abnormal bone and replacing it with a metal spacer. There's all sorts of different types, different companies that use them. It's essentially an off-the-shelf implant, so we don't need to pre-measure too much. We need to know essentially how much we're planning on taking. So there are a few differences in sizes, but overall pretty standard. And really this is only intended for the distal radius. So it's just a couple of images there. This is one of the implants that are available. So this one is the tantalum endoprosthesis that Biometrics makes. And so the thought here is that potentially there's some osteointegration and encouragement of local bone formation. This is an example of a metal endoprosthesis. This is the one that we use most frequently. There's a lot of hardware in there. So there's a lot of metal in there. And it's not surprising that that's going to have a high risk of infection. This is the lateral manus translation. So this is the case that we had here. Again, confined to the radius. There's a little more soft tissue swelling, but he didn't have any breakthrough of his cortex on CT. The ulna was completely intact with no changes. And so in this case, essentially what we're doing is we're rotating the weight-bearing surface from the radius to the ulna. And so with the hardware to help attach and hold that, we're translating that surface of ambulation. So in all of these cases, the post-op treatment is fairly similar. They're on analgesics. Sometimes we'll use a pain catheter for things like the proximal, for the scapulas. We generally tend to avoid pain catheters in the limb spares. The reason for that being is we're already so worried about infection. We don't know for sure the incidence of or increased risk of infection associated with pain catheters, but in my mind, if I have anything going out of a wound, then it means something can go in. And so even when we're using pain catheters in any sort of patients, we're always wearing gloves, we're cleaning the area, we're making sure we're using a clean bottle. So we're really being very, very careful about our sterile technique, because just like a drain, there's definitely risk of getting contamination. A lot of these guys are going to be kept bandaged for 4 to 6 weeks. And in these situations, we may actually leave a drain in, just to be able to try and decrease any local fluid accumulation. They're on pretty aggressive antibiotics for a period of time. And they're often in hospital for somewhere between 3 to 5 days and up to a week. And most of these guys will start walking on the limb pretty quickly. So as I said, in the vast majority of cases, these are dogs that need to have that limb. We don't have an option of removing the limb, and so they will use the limb. And so we have to make sure that what we're doing in our repair is able to withstand that as well. It's not like a person where you can sort of say, okay, now you're in a wheelchair for 3 months, let it heal. We have to be planning all of our surgeries and being prepared for the fact that they're going to be using that leg. So the main concern with these guys is 30 to 70% of them get infected. So I tell owners about 50-50. That is a really high number of cases that are getting infected. Some of these guys will get infected and we can manage that. We sometimes have to do multiple surgeries. We can lose part of the skin associated with that. We can be dealing with open plates, exposed, and having to manage that. It's not fun. It's not a positive situation. And so the owners have to really be prepared for what are their expectations going through and how much are they willing to go through and what risks are they willing to take. There's implant failure in about 40% of cases. In about 10% of cases, that's catastrophic, so non-salvageable. Whereas in 40% of cases, there's screws are breaking, implants are backing out, things like that. So really not for the faint of heart. Local recurrence is thought to happen in about 1/4 of cases. And so that has to do with the fact that we're having to save those soft tissues. And a lot of that is case selection. So we can't take a lot of that soft tissue around the periarticular region. And so sometimes we're going to see local recurrence in those areas. There's some thoughts about using local release chemotherapy agents and things like that to try and decrease that. Sometimes we'll manage local recurrence with radiation, sometimes amputation, and then in very rare cases, we're talking about second limb spares. And as I said, a lot of the costs associated with these is going to be somewhere in the range of $8,000 to $10,000. And that's the ones that do well and don't necessarily need multiple surgeries or have major complications. So there's about $4,000 to $5,000 worth of hardware in some of these guys. So the procedure alone, we don't really mark up the procedure because we're dealing with such an expensive thing to start with. But they really have to be prepared to spend a significant amount of money and deal with a fairly long, drawn-out process. If things go well, and when they go well, they tend to go pretty well. So they cosmetically, the owners are quite happy. The leg looks pretty normal. So the implants and everything are internal. The skin is closed over top. The skin should heal appropriately. And so functionally, these guys look good and they tend to use the limbs quite well. Some of them will require post-op rehab or things like that. And a lot of that just depends on the patient to start with. You know, if they're overweight, having to deal with some of those complications and things. These are generally animals that are orthopedically unsound to start with. I'm going to just very, very briefly go through prostheses. So prostheses typically are in animals are reserved for the distal limbs. So again, amputations that are happening kind of at that mid-humerus is quite hard to do, but sort of mid-radius or mid-tibia. Forelimb versus hind limb, there's some debate as to which does better, but we know that they're more weight-bearing in the forelimbs, which is a concern. And then management in these guys can be very challenging. So there's lots and lots of reports out there of dogs with these endoprostheses or internal prostheses. And if you can find someone who does a great job of managing them, who can work with them, then they can do well, but they're certainly not straightforward in themselves. There's also some techniques of what's called osteointegration. And so you're actually implanting a post within the bone, covering most of that edge with skin, and then that bone post interface will grow together, integrating. So that's where the osteointegration part, and then you hook that into a prosthesis that's external. And so that's something that is out there. There's a few cases here and there. More often it's being done not for tumors, but for animals that are born with partial limbs or that have traumas that can't have amputation because there's multiple limbs involved and things like that. But again, not the most straightforward to deal with. The nice thing with the osteointegration is in general, they tend to be a little bit less complicated from a management perspective once you get things sorted out. But the challenge for us is often actually sourcing an implant. So right now we may have an ability to access some 3D printed implants that are being done in down in North Carolina. And so if you did have a client that was interested in this, that you had a specific case, it's something we can consider, but as a rule of thumb, not something that we're not offering it. But if we had the right case, we could certainly talk about it and discuss it. But generally, I think the take-home message with all of this is that dogs do really well with amputations. And so it's really important to have that discussion with the owners and make sure they're understanding of that first. So.
Is everybody awake still? Okay, so we are going to move on to playing with fancy toys. Welcome to 21st century treatment. So I'm just going to briefly talk about radiation treatment. As Michelle said, surgery followed by chemotherapy is considered the gold standard treatment for osteosarcoma. But there are some occasions we consider radiation treatment. So especially when we consider radiation treatment, especially when primary osteosarcoma is not resectable, and when there is a concurrent disease in the patient, such as neurologic or orthopedic disease. And also when owner is against surgery, especially amputation, we consider radiation treatment as an alternative treatment. These are the protocols that have been used in veterinary medicine. So those fall into two big categories, which are palliative RT and curative RT. The purpose of palliative RT is relief of clinical symptoms such as pain and lameness, while we are trying to minimize the radiation-induced side effect. But with curative RT, we are aiming tumor necrosis. Some research detailed the significant tumor necrosis in osteosarcoma after radiation treatment, and those research became a basis of investigation of curative RT. Currently at OVC, we are capable of providing all these protocols, but our preferred recommendation is 2-fraction palliative RT. And I'm going to explain the reason in next slides. So these are the reported data regarding outcome of radiation treatment. But if you look at median onset of response and duration of response and response rate are very similar regardless the protocol. So this is a summary chart. So this table is basically comparing the palliative RT versus curative RT. Most most of the results are very similar, but if you take a look at side effect rate, curative RT has a higher chance of side effect comparing to the palliative RT. But we have to admit that the data regarding curative RT is limited, and also not all patients are eligible for the curative RT. So what does it mean? So we can say radiation treatment is very effective in alleviating pain with fast onset. In most recent literature, the patients are treated with 2 fraction by 8 gray on 2 consecutive days, and 91 patients responded within 2 days. And also, most of the paper reported that high percentage of patients responded well to the radiation treatment, the ranging from 78% to 91%. So, but there is a concern regarding radiation treatment. Pathologic fracture is the primary concern, especially when the pathologic fracture is present prior to the radiation treatment. We cannot really expect a substantial palliative effect from the radiation treatment. Also, after the radiation treatment, we have to be careful monitoring the recovering from the anesthesia, and also after the completion of radiation treatment, we have to be very careful caring the patient. And also, the radiation treatment has a relatively short duration of pain relief. The report saying that usually this pain alleviation effect lasts between 76 to 130 days. And also, radiation treatment does not affect median survival time, which is very similar to the amputation surgery alone. The last comment about the cost, I think I have to change about this, because after I saw the Michelle's presentation, the radiation treatment is much cheaper than $80,000. We usually charge for the $2,000 to $3,000 for radiation treatment. So now let me introduce Brody. Brody is 10 years old, Castrate male, Westie. Initial presentation was weight-bearing lameness of left thoracic limb, and chest radiograph was done by a referring veterinarian. There was a questionable aggressive lytic lesion associated with soft tissue opacity in the left first rib. Physical examination revealed a severe non-weight-bearing lameness of left thoracic limb, and there was an ill-defined mass effect in left deep axillary region with enlarged from left axillary lymph node. And finally, the aspiration was performed. The result came back as suspicious soft tissue sarcoma, and axillary lymph node had evidence of metastasis. And true cut biopsy came back as osteosarcoma. So this is a CT scan done. And as you can see, there is a giant mass originated from left first rib. And the left first rib is almost destroyed. And also there was a pulmonary nodules present. And mediastinal lymph node was enlarged as well. So at that point, the surgery was not an option. So the owner elected to go with palliative treatment with palliative RT 2 fraction by 10 gray weekly. At 2 weeks post-radiation recheck, there was a significant improvement. The limb function became almost normal, and there was also significant reduction in tumor and lymph nodes. Lymph node measured 1 centimeter in diameter at that moment. So we started palliative treatment as a systemic treatment. But at 2 months post-radiation recheck, there was mild lameness appreciated, but in terms of tumor size and lymph nodes, those were stable. But there were new lesions. One was ocular mass in left eye, and both bilateral publicity lymph nodes was enlarged. So those were suspicious of metastasis. So this case reflects that radiation treatment was very effective in local tumor control but it did not affect their metastasis. Thank you very much, and I'm gonna pass on to the chemotherapy. This one? Okay, what about the pointer? You busted it. Okay, thanks. And what about the pointer?
I'd rather have such demand.
Sorry. Yeah. Hello, I'm a first-year resident in oncology service. So my presentation is basically about bisphosphonate. It's going to be very quick. I just wanna go over a case. I think we have like time to discussion after this presentation. So I'm very happy to answer any questions. So if you get any questions, please let me know later. So basically, bisphosphonates, which is a drug, inhibits osteoclast activity. And then osteoclasts basically destroy bones as a part of the normal balance between bone absorption and deposition. So basically, we have osteoclasts in the bone, and then osteoclasts can try to destroy bones. Then bisphosphonates basically inhibits the osteoclast activity so that we can reduce the bone destruction furthermore. And then the inhibition can help with pain control and potentially tumor growth in vitro, but we don't know whether it's actively effective in terms of tumor inhibition in vivo. And the most common drug we use in veterinary medicine for bisphosphonates is something like pamidraronate. So pamidraronate can be given intravenously infusion over 2 hours every 4 weeks, almost monthly. This drug is the first treatment choice in human medicine for malignant bone destruction. And that's why we do use the same drug in veterinary medicine. And then we actually have some literature. Renal toxicity is the most common side effect in human medicine, but rarely reported in veterinary medicine, interestingly. In one report of 43 dogs with appendicular osteosarcoma, they used bisphosphonates given over 2 hours infusion. And then the reported pain control duration was more than 4 months in 28%. And the median time of pain control was around 8 months in this population. So it's quite good. And then, as I said, potentially there was a synergetic effect with radiation therapy in vitro study, but we don't know whether it's actually working in a good way in vivo. So the case is Jack. So he's an 8-year-old male castrated golden retriever. Came to us with a 1-week history of right thoracic limb lameness. And then a radiograph was taken at the referring vet, and then the veterinarian found aggressive lytic lesion of the distal radius. So it's typical location for osteosarcoma. Amputation and chemotherapy were declined by the owner for some reasons at the referring vet. So basically, Jack came to here for more palliative options such as radiation therapy, as Dr. Kim said, or some pamidraronate. So our treatment plan was basically doing 2 doses of radiation therapy. Basically, this is our standard of palliative radiation protocol for dogs with appendicular osteosarcoma. And then we did offer pamidraronate, which were given monthly. So this is kind of history how we did manage Jack. On day 5, we did manual planning for radiation therapy, and then we did give first dose of radiation. And then we gave pamidraronate at the same visit as well. Then radiation therapy was given 7 days later. And then basically we gave pamidraronate every 4 weeks. Jack developed somewhat like mild lameness at the day 7, which was addressed with fentanyl patch at the referring vet for a few days. And then the lameness gone. But the Jack also developed some mild lameness on day 105. So we did add some gabapentin and tramadol, but the lameness was still stable. So we did add amantadine on top of that.
but the lameness was still there. So, however, Jack was still doing okay at home, still eating well, still walking very well with mild lameness. However, on day 201, finally Jack developed very, very severe lameness on the affected limb. So we did discuss again for the amputation chemotherapy options, and then finally Giona decided to amputate the leg. Histopathology came back as osteosarcoma. So in this case, we did very well manage the pain with radiation and permethrinate for almost 7 months. So that's a good case. We give carboplatin as a standard treatment for dogs with osteosarcoma, and then he's still alive at the time of day 285 without any metastasis. So discussion point for this case is, as I said, we could manage the pain very well with the radiation and permethrinate for 6 months. Although I didn't mention, in this case, we did measure creatinine level at the time of permethrinate infusion, and then he didn't develop any side effects, any GI side effects or renal toxicity. And then, so permethrinate could be a reasonable option for dogs not undergoing limb amputation as a palliative care and pain management. So for discussion for this case is that, so we don't know whether permethrinate is actually effective in terms of tumor growth. There was a recent study looking at the impact of permethrinate on dogs with appendicular osteosarcoma. So they did include 31 dogs with amputated osteosarcoma, and then they compared outcome with in dogs treated with carboplatin alone or carboplatin and permethrinate. And then there was no significant difference in survival time. So on microscopic disease, probably we are not doing very good job in terms of tumor control with permethrinate. But there are some other bisphosphonate drugs such as zoledronate. And then there were 2 papers looking at the efficacy and safety of the zoledronate. So these are something maybe we can consider in the future. Thank you. Then Dr. Mutsaers.
Slides that I know I will.
Oh, you should be fine. This one's the pointer. Just this is just a pointer.
Oh, okay. Great. Hi, everybody. I can tell you after Arata's talk that I'll keep this one very short as well. My name's Tony Mutsaers. I'm one of the medical oncology faculty, and I, as a medical oncologist, am charged with going through what's tried and true in the way of chemotherapy and osteosarcoma. So is there anything new on the horizon? Are we doing things any differently than we have been to treat osteosarcoma with chemotherapy over the last dozen years, 20 years, 30 years? And really quickly, I can say, in effect, the answer is no, with a couple of interesting things on the horizon. And so this 5-10 minutes will kind of set the stage for things we can do perhaps to improve the overall outlook for osteosarcoma. Because as much as we focus on the local disease, surgical options, radiation therapy for candidates that can't have amputation, what kills the vast majority of these dogs is metastatic disease to the lungs. And so we need to do a better job in improving the suppression or eradication of metastasis to make real progress with this disease. So what do we do with chemotherapy? We know that the vast majority, over 90% of cases, have metastasis at the time of diagnosis. So we do a complete staging workup, we look for these, and we don't find them in the vast majority of the cases, but we know that they're there. And when we use chemotherapy, the traditional cytotoxic form, we get really nice statistics. In oncology, it's a bit of a rarity to be able to offer owners a lot of statistical power to predict how well they'll do. There's a lot of diseases that are a lot more rare that we have less numbers for. But with osteosarcoma, it's pretty tried and true. 3 to 5 months, 4 months, amputation alone, no follow-up therapy with something systemic. Versus adding a cytotoxic chemotherapy agent, we get 9 to 11 months. And it does not matter which chemotherapy drug we use. We have our 2 favorite families, the platinum agents and the anthracyclines, the doxorubicin. So is it wrong to treat with cisplatin? Of course not. Or carboplatin or doxorubicin. As single agents, they all have very similar outcomes. So there really is no superior protocol. Why do we use carboplatin? Why is it our #1 choice? Well, it has a similar efficacy to cisplatin, and as you probably know, is a lot better tolerated by the kidneys, a lot easier to administer. And as the price, which used to be restrictingly high, came down to equivalent or similar affordable to doxorubicin, it became a much more palatable choice. It's not wrong to use cisplatin. And the next logical question with these drugs is, if carboplatin works and doxorubicin works, what about alternating the two or even combining the two where you give approximately half of each every 3 weeks? And again, I could cloud this with a bunch of Kaplan-Meier survival curves comparing the different chemotherapy protocols, but they would essentially all look about the same. And unfortunately, I don't have good videos. I just talk about drugs and how well they do. So it's all numbers on these slides, but the similar outcomes regardless of which drug you use. However, if you get into what's novel or what most people are thinking about how we might improve upon these, it's in areas like the use of metronomic chemotherapy. So if you've heard of this term metronomic chemotherapy, it is used to define a concept that, yes, uses the same drugs, in this case cyclophosphamide because it's an oral drug, it's easier to administer, on a schedule that is vastly different from our cornerstone of cytotoxic therapy, which is giving as much as we can and then inevitably waiting for the potential side effects to clear before giving that second dose. So low-dose cyclophosphamide has been used as a metronomic continuously applied schedule in an attempt to inhibit angiogenesis or change the immune environment to suppress metastatic disease. And there has been some promise with low-dose protocols, potentially in hemangiosarcoma, another very metastatic disease, in potentially preventing recurrence of soft tissue sarcomas. And so it stands to reason that we might be interested in either combining low-dose metronomic cyclophosphamide with what we currently use, doxorubicin or carboplatin, or perhaps using it on its own to suppress metastasis and osteosarcoma. We don't have any large trials out to date. However, there is one that's showing that low-dose cyclophosphamide may indeed not be all that effective in suppressing metastasis, either on its own or in combination with Palladia or troserinib phosphate, the other drug where there's a lot of interest in how it might be applied to this disease. And in fact, with our own data here at OVC, we've looked at cases where we've treated with low-dose cyclophosphamide after we finish our conventional carboplatin protocol. And even though the data is still coming through and it's retrospective, we offer it to clients and some will take it and others will not. It does replicate what we're seeing in sort of our specialty, that there is not a lot of activity with the particular protocols we've tried. So how does that compare with Palladia? So Palladia, as you know, it's a multi-kinase inhibitor that's been approved for recurrent and metastatic mast cells that are driven by a mutation in KIT, but it targets a number of different targets besides KIT: VEGF receptors, platelet-derived growth factor receptors, a number of molecular alterations that maybe not just mast cell tumors have, but other tumors as well, including perhaps osteosarcoma. So you can imagine with a disease with an outcome like this, where almost all cases die of metastatic disease, is there a potential for troserinib phosphate to have activity? And interestingly, when again added as some sort of maintenance regimen after you're finished carboplatin or doxorubicin, there doesn't appear to be a lot of efficacy in, again, delaying the onset of metastasis beyond what we expect at the 10, 11-month mark. But where we have seen it, and again, I must stress these effects are now, for the most part, transient, is in an area of therapy where we haven't had a whole lot of promise. And that's after the detection of those lung metastases. When the vast majority of our chemo drugs do absolutely nothing, there are, in approximately half the cases, a clinical benefit to adding Palladia at that time. And clinical benefit, I should say, is defined in an interesting way. It's not necessarily always shrinkage of those lung nodules on a repeat X-ray a month down the road, 2 months down the road. It's stabilization of that disease. You may find a lesion or two. On Palladia, those lesions may stay exactly the same size going forward, which we consider a clinical benefit. So I'll give you a case that kind of exemplifies the conventional response to this type of systemic treatment approach in osteosarcoma using COOP. So COOP had a 4-month history of progressive lameness, an aggressive lytic lesion of the proximal humerus, a dangerous area prognostically even in osteosarcoma. He was treated with limb amputation, and then our standard, which is 4 doses of carboplatin. So again, questions about chemotherapy, carboplatin, cisplatin, doxorubicin, we know they're all the same. Another one that comes up even more often now is, in the face of no visible metastatic disease, how many carbos do you give? Some people give 4, we give 4. Some people give 6, some people give 5. There are trials coming out that compare, is 4 doses of carboplatin any different from 6? And it appears, at least at this point, that there may not be any difference in that number of doses giving. So more doesn't necessarily mean better. As I mentioned, COOP was offered this low-dose metronomic cyclophosphamide chemotherapy at a dose we think has biological activity, 15 milligrams per meter squared daily, after the carboplatin was finished. And then staging for rechecking those thoracic radiographs to remain clean every 3 months. So if you look at the carboplatin protocol around day 25 through day 96 to get those 4 doses in, everything's still clean on chest radiographs. The cyclophosphamide dose, as I mentioned, is 15 milligrams per meter squared daily, and we combine that with a non-steroidal anti-inflammatory drug. The reason for that is not analgesia per se, but the literature that embodies a potential anti-cancer effect with some non-steroidals like piroxicam and perhaps others like meloxicam as well. And the fact that they may actually work together better than either drug alone, although we haven't got prospective clinical trials to bear that out. By about 5 months, there's been no side effects from this well-tolerated continuous therapy and normal blood work. But by about the 6-month mark, we see what, again, we expect to see, and that's pulmonary metastasis. So at that point, I mentioned Palladia being a potentially active drug for this scenario, and the dose being above 2.5 milligrams per kilogram. And again, there's a bit of debate about what type of dose compared to the label is the most effective for Palladia, and we use anything above 2.5 mg per kg on a Monday, Wednesday, and Friday schedule. As they get Palladia, in these cases that are on low-dose metronomic cyclophosphamide, we try to keep them on the combination. So from 6 months, a couple of weeks later, no side effects from the Palladia institution, and then at about 8 months or so, progression seen on radiographs. So the original pilot retrospective data on Palladia in about 23 dogs showed about half had this clinical benefit, and really only 2 had an objective shrinkage of their tumor with Palladia. And in COOP's case, there was progression documented by 8 months, which began to progress again, and by 280 days, he was euthanized for the disseminated metastatic disease. Again, if we're going to make any progress with this disease beyond what's tried and true with chemotherapy, we have to have newer, impressive targets to thwart this metastatic progression. So in review of just this small chemotherapy section, we know our statistics are fairly well worked out, and that bore out in COOP. We have these potential targets, potential drugs to introduce like Bisarenib and other chemotherapy drugs. We know that there's a lot of work to do, and the efficacy of things like low-dose cyclophosphamide and meloxicam are still, at this point, in relative question. And indeed, for this evening in particular, this is probably a good introduction to the fact that novel systemic therapies are not only needed, but clinical trials, including those at OVC, are going to be starting up soon, looking at some of the more attractive treatment options.
Thanks, Tony. And now just introduce to our next thing, which would be some of the treatments we have. And so as Tony was saying, we're looking for a better way to treat osteosarcoma in dogs and some of that as well. So in the American National Institute of Health has a comparative oncology trials consortium, and we're their only international member. And what the consortium with the National Institute of Health is looking at, they're recognizing that the osteosarcoma we're seeing in dogs is very similar to the osteosarcoma in people. And probably there's more big breed dogs coming down with osteosarcoma here in North America than there are teenage kids coming down with osteosarcoma. So if we can make a positive difference in the pets, some of that may also translate to helping people as well. So we're propitious to have this meeting tonight with osteosarcoma because we've just had a new trial that the consortium has opened and is sponsored by the Morris Animal Foundation. And so we well, we basically have just introduced this week because we got our agreements in check. And so we also have this booklet, as I mentioned earlier, that Christine has out at the table, has clinical trials in it. And this is a trial that is open for your clients. And so what we're looking at there is looking at standard of care, which as Tony was mentioning, for dogs who have appendicular osteosarcoma that have no evidence disease other than what's on their leg. Standard of care would be amputation followed by chemotherapy, carboplatin for 4 doses. And then what they're looking at is they're going to randomize the dogs to that standard of care, or they're going to add to it rapamycin orally that the clients would be giving to their dogs at home for another 4 months. And so our inclusion criteria, and again, this is in the book, so you don't need to go into that, but net effect is I need dogs who are over 25 kilos in size, who have no evidence of disease other than their legs. So we do staging ahead of time, which would be physical exam, and as Jerome was mentioning, thoracic radiographs, abdominal ultrasound, have had no previous therapy for osteosarcoma, and have no other significant disease. Then if they come to OVC, what they will be doing is they'll be randomized into the study. And the advantage for the clients will be that this is the consortium study is funded by the Morris Animal Foundation. They're going to pay about $1,000 towards the amputation and the workup of the pet. And then what they'll do is pay for all the pre-treatment, complete blood counts, biochemical profiles, and urinalysis. They'll pay for the carboplatin for the administration and the chemotherapy itself for 4 treatments. And for those dogs who are randomized to the rapamycin part of the study, they'll also pay for the rapamycin. They'll also pay for follow-up physical exam and thoracic radiographs. So we're looking for substantial investment by the Morris Animal Foundation, but what they're looking for is, as Tony was saying, is there something we can do in addition, such as rapamycin orally, and make a difference in survival of these pets? So again, study is just opened. Vicky has put it together in here, and Vicky and I will be available afterwards or to talk to us about some of your pets who may fit into that study. So there's all you need to know is Vicky Sabine, where to catch her. And just as an aside, one other thing that's come up, well, I shouldn't say that. So what we're looking at is targeted therapy, and how this is going to be working is, I won't get into microbiology at this point, but just be looking at receptor tyrosine kinases, and if my printers had, or pointer had worked, just be looking at the AKT aspect there. So, oops, sorry. Keying in on this guy here, and just be looking at rapamycin, which has been used orally in people for immune suppression for a number of things in people, is looking at affecting the AKT, but also looking at some metabolic processes in people as well. The nice thing with rapamycin is that they've also, the consortium's done a study to show lack of toxicity for the pets as well. So we know that dose would not be expected to be toxic for the dogs, and the effect there is molecularly maybe affecting the growth and differentiation of the osteosarcoma. As an aside, for those of you who are at ICCI Symposium last spring, another is immunotherapy, and this is a group in America, Aratana, and again, just be looking down here, is they have a vaccine coming on for osteosarcoma. I'm just not sure when that's coming to America or coming to us. And this is from Dr. Nicola Mason from Pennsylvania, who was here last spring. And basically she's found that dogs have increased HER2 expression in dogs with osteosarcoma. She's got a genetically modified listeria that she uses to vaccinate dogs against HER2/neu, and that vaccine will be coming at some point into America. Once they've done the trials there, then will be coming up to Canada. And the idea of that is using immune therapy on top of standard of care amputation and chemotherapy. So again, looking for another way to increase the survival of dogs. So the quick trade back is the Morris Animal Foundation sponsored COTC study is open now at OVC. Immune therapy yet to come. And prognosis.
Okay, so thanks, Steve Patton. I'm the second-year medical oncology resident here. I don't think I'm going to offer anything new. I think that most of the information I'm going to present has kind of been sprinkled through the other presentations today already. But I mean, it ultimately, at the end of the day, this probably is the most important piece of information, or the biggest thing that especially our client owners are coming and they're going to be asking about. And that, of course, is associated with these local therapies, surgery, radiation, and then systemic treatments. How successful are we being at treating osteosarcoma in our dogs and our cats? So it's been mentioned already, but there are a number of prognostic factors that have been worked out from the treatment of osteosarcoma. Age, the sort of biphasic distribution of these patients. So younger patients are unfortunately associated with a worse prognosis. The size of the tumor, the anatomic location, again, it was mentioned, the humeral locations being associated with a more aggressive phenotype. Grading schemes also exist, which take into account things like mitotic indices. Serum alkaline phosphatase. This has been mentioned. There's a couple of theories here, one being sort of that absolute value, sort of different thresholds greater than 100 units or 23 respectively for either the total or bone isoenzymes respectively. They've been associated with worse prognoses as well. And then there's the idea of sort of serum alkaline phosphatase, both pre and post amputation, if we don't see a significant reduction, and it's thought to be related to kind of overall burden of disease. And then, of course, fairly intuitive whether or not there's evidence of metastasis at the time of diagnosis. So patients presenting with measurable metastatic disease, having a fairly poor prognosis, 76 days is a median survival. In contrast, or patients with or without lymph node metastasis, so with 58 days and without, as much as 318 days. Again, anatomic location, so the difference, we've talked a lot about appendicular osteosarcoma. Other bones in the body get it as well. And so particularly, so the exoskeleton, so the mandible, the maxilla, the skull, in general, sort of, they are typically associated with a bit of a better prognosis. They're a bit less metastatic. So you can see reported here, median disease-free times of 191 days, median survival times of 204 days. Rib locations are listed here as well. The scapula as well. There's also extraskeletal forms of the disease. And even within there, it can be fractionated more as to specific sites. So we know that, for instance, mammary gland osteosarcoma tend to do worse than other locations of extraskeletal osteosarcoma. This is actually just the same information presented in a graph form. So for our typical appendiculars, though, how are we doing with them? So with amputation alone, it's been discussed already that it truly is palliative in nature. Really, we're just dealing with the pain and discomfort associated with the disease, and I guess reported about 90% of these guys will die within about a year from their metastatic disease. When we treat with radiation therapy as our primary treatment and in combination with systemic therapy to deal with as microscopic spread of disease, median survival times, on the order of around 209 days. And then sort of gold standard of therapy, amputation plus chemotherapy, reported when you looked at the literature, median survivals anywhere from 207 up to, getting close to a year. So when you take all this information together, being a bit repetitive, but surgery alone truly is palliative in nature, and it doesn't do anything for overall survival. When we include chemotherapy, that's where we have that potential, as Dr. Mutsaers was showing, to improve our median survival time up to as much as a year in some circumstances. The goal of radiation is really more about alleviating pain, and with a fairly high response rate, although unfortunately it's not durable. And so, median times for pain relief reported anywhere from 53 to 130 days. In contrast, we've spent a lot of time talking about dogs. We haven't really mentioned anything about cats. It's a bit of a different disease. I mean, not pathophysiologically, but in terms of, the way we treat the disease and how our feline patients respond, it does tend to be a less metastatic osteosarcoma tends to be less metastatic in our feline patients. So usually we're just typically treating with amputation or local therapies alone, and median survival times reported anywhere from 24 to 44 months. Anatomic location playing a role as well in our cats, affecting axial sites. 6 to 6.7 months is what's reported, which is in fact lower than the appendicular extraskeletal forms of the disease. And histologic grade also playing a role. Again, mitotic indices having a significant role in the disease recurrence-free intervals.
Okay. And so, yeah, we are part of the Institute for Comparative Cancer Investigation here at Guelph. And so we have a number of studies going. Osteosarcoma is one. And as I mentioned again, Christine has these at the back and Vicky's made them up as well. And we're just going to finish off here and then we'll open it up to discussion. Maybe not.
We could be heroes. Yeah. Hey, like a wolf pack, we in this together. Sun, rain, stormy weather. Through it all, we help each other stand up. Now let me see everybody put your hands up. And catch me, I fall to the ground.
So again, thanks again for coming tonight, and thanks for the Pet Trust for supporting us. What questions do you guys have? Or what comments? Dang, come on down and answer all these questions. Yes.
Are you promoting at OVC a lot of antioxidant supplements in conjunction with some of the chemotherapy and radiation that's going on?
Question was about antioxidants, not so much for treatment, because a lot of the stuff that we're doing with radiation is dependent on free radicals. So if they're on the pets are on antioxidants, when the time we're doing radiation, we'll ask them to be off that for that period of time. Again, not such a big deal for osteosarcoma because it's more palliative, but for our other diseases where we're doing more of a curative intent, like soft tissue sarcoma or mast cell tumor, I need them to be off the antioxidants because it could quench my radiation. Again, with the chemotherapy, some of it will be fine, but if we're using something like doxorubicin for some of the chemo, I need to have them off the antioxidants for that period of time because, again, it's going to quench our therapies. So for treatment times, it depends on the treatment and asking the clients what supplements their pets are on.
Okay, so then, but after you've done their
Yeah, so after they're fine to go on to do antioxidants or other supplements if they want to try that. Yeah.
Are there any particular that you're promoting at OVC in conjunction with?
No, the question was, not really. The question is, do we promoting antioxidants? We're not at this point, because that's something that may be helpful before the dog or the person, sadly, ever got cancer. So by the time things are happening now, I don't have a lot of data to show antioxidants helping to fight cancer itself. Okay. But I have to put in my plug, sorry, as I suddenly realized, we also have Androni Verbach, who is our nutritionist as well, who is also helpful for supplements as well. Similar to Danielle Richardson that we said at the beginning, Androni is off right now because she's just had a baby, but we also have Jackie Parr helping us as well. So if there are nutrition questions on supplements, they're another resource we have at OBC.
In human medicine, often the radiation treatment is like 30, 35 treatments. In this medication, in this treatment regime here, it's 2 to 4 treatments. Is it higher dose rate, or why the difference, I guess? The question was different protocols. For us, for osteosarcoma for dogs, we're just doing palliative. We're just doing pain management. And some other things that we may get to would be stereotactic radiation, which would be sort of a form of limb spare. We're actually treating it. The question in people, I'm not sure what they're doing for radiation on that part. If they're doing many treatments, so they're going to go for more of a curative or definitive approach. Some of the other treatments, just to go sideways, not osteosarcoma, but mast cell tumor, or say soft tissue sarcoma, there we'll do 15 to 20 treatments, or nasal tumors will do around 10 treatments. The thinking there is we want to get a small amount of dose in so we don't have such severe effects. Our trade-off is our pets. They're not as amenable as you and I, and so we have to anesthetize. So it's a trade-off in that we're using a short-acting anesthetic to get them down, and then from there getting them back off gas quickly. On the other hand, that's another reason that our fractions are often not as spread out as they would in people, where they could just put your hand in there, treat it, come back 6 hours later, treat it again. We would need to anesthetize the cat or dog twice. Yep.
The genetic link between early spay neuter and osteogenic sarcoma or other cancers?
Yeah, so the question there would be, the gender status for the pets, not so much genetic, but even just a gender status of spaying and neutering of dogs for osteosarcoma. And that's where people are looking at that to say, is there a protection to be intact versus spayed? But it does come down to the genetics will come down to it is what is the risk benefit for that dog? And that's something that people need to look at. If it's a small dog who's not likely to get osteosarcoma, then if it's female, you'd be thinking, spaying will decrease the chances of mammary carcinoma so much, there's advantage there. But if it's something like a greyhound who has a higher chance for, to pick on racial profiling, a Bernese mountain dog and saying has a high chance of getting something like a osteosarcoma, then maybe that dog might be better to be intact. We're not looking at that here at OVC, but others are with epidemiology looking at bigger numbers. And so our shoot from the hip saying, let's spay the female dog, they'll do better because they won't get breast cancer, may not always be such a risk benefit for some of the bigger breed dogs who may have a chance of getting osteosarcoma. But you still have to look at what are the chances of getting one cancer versus the other. And certainly breast cancer in countries not like ourselves who have much more intact females seems to be a much higher prevalence than osteosarcoma. But we have to get our gang down here because people are tired of hearing me talk. What other questions do we have for the surgeons? Okay. Well, I'd like to thank you all for coming out tonight. If you have any questions, though, come and talk to us. As I said, Christine at the back, who put it all together, thanks again. A faux pas. I have to check with my social media person. Do we have any questions coming in on the internet? We do not. If we do, we'll talk to them later. So thanks again. Christine's interested. If anybody could tell her if you signed in and are already here. And again, Vicki Sabine is at the back, who's our clinical trials coordinator, waving her hand in the air. And so if you have any questions, not just for osteosarcoma, but again, Byron Bridle and I have a study looking at oncolytic viruses for cats with mammary carcinoma and other areas as well. Thanks very much.
Mm-hmm.